I have the privilege of introducing Dr. Kylea Potvin now. Kylea is actually one of the newest members of our medical advisory board at Kidney Cancer Canada, and we're thrilled to have her join that group. Kylea is a graduate of McMaster University in the year 2000 and completed her internal medicine at Dalhousie University in 2003 and was the first resident through medical oncology subspecialty training program at Dalhousie. So very excellent. She's currently an assistant professor at the University of Western Ontario and a consultant medical oncologist at the London Regional Cancer Program. Her tumor sites are breast, genitourinary, which includes prostate, bladder, and testes. And she has a strong interest in education and therefore currently is co-chair of the undergraduate oncology education, as well as sitting on the postgraduate education committee. Her research interests are also in locally advanced breast cancer and education. And of interest, she's also a mom and a classically trained singer, so maybe we'll get an added benefit tonight. We can turn it into a fundraiser for Kidney Cancer Canada. So please join me in welcoming Dr. Potvin.
I think all those other things are way more interesting than being a doctor, so.
Is this you?
That should be right there. Yeah.
Perfect. I'm a wizard now.
You are. So it's very, very nice to actually be here talking to you, and much like Dr. Putler was tasked with the idea of talking about how do we surgically manage this and what we do with early stage disease, I actually come into play in a much later aspect of the disease. So when I talk to you tonight, this is more about the systemic treatment of cancer, because that's what I do as a medical oncologist. I deal with more things like chemotherapy and drug-targeted therapy. So what I was going to do with this talk is, as opposed to just sort of focus on a couple of drugs, or I will specifically talk about this, but I think in order to a little bit help you understand the drugs and why they have the side effects they do. Sometimes it's kind of nice because we talk about kidney cancer and different kinds of cancer, but I think sometimes it's nice to know what cancer really is. I think, if I were to ask you different definitions, I might get some different ideas. So I'm going to try to, in reasonable terms, explain to you a bit about what cancer is. There's a big fancy word up there called angiogenesis in cancer, and you are going to understand exactly what that means by the time we're finished this night. You are going to be experts on this. And I'm going to talk to you about when we actually do introduce drug treatments with kidney cancer, because it is different than other tumor sites at this point in time. And then we'll specifically talk about the drugs that we are currently using. And just a brief note at the very end, a little bit about the importance of why we do studies and what are called clinical trials. So when we talk about cancer, I mean, it's a parasite. It's a disease of growth. But you can have growth in the body that actually is not cancer. There are things that happen that will change a growth from being just a growth, because we can have them. If you have the capacity for cellular change, we all do. Your hair grows, except in men of certain ages. Our cells turn over in our bodies. We have cells, our blood cells. We have cells that are always changing, always growing, always dividing, and it's a necessity of life. We have to have healing capacity in our bodies. So the potential for cancer has always been there. And we actually all have genes in our bodies that are responsible for maintaining control on cellular growth. And that's the problem with cancer. It takes what are actually normal processes in our body and changes them. Something happens to turn certain things on and certain things off to cause these cells to throw off what should be the controls on their growth. And that is what can lead to the development of a growth that can become a cancer. So this looks like a really busy, scary slide. Don't worry about it too much. What I want you to take away from this, and I'm going to describe some of these terms for you. This is what happens in our bodies and in the cells when something turns into a cancer. These are called, what we currently understand are the things that happened. And there are going to be some terms here. I'm trying to find this. So what we're looking at is we have genes in our body, and we've heard about VHL. This is a gene that actually appears at the cellular level. It's a gene that can be carried on our chromosomes. But we have what are called tumor suppressor genes. We have things that are called proto-oncogenes. And so these are some of the major controls that happen in our bodies to help control cells. Should they grow more? Should they grow less? These are the stop gaps. This is what stops growing and dividing cells from getting out of control. So some of the things that go wrong in the cancer cells, in cells to turn them into cancer, are this. Evading growth suppressors. So what will happen is certain genes that are supposed to stop growth, something happens and those genes become abnormal, and all of a sudden they're not there to stop the growth potential from happening in a cell. So cells can now start growing because there's nothing to put the brake on them. Cancer cells are very smart. They develop mechanisms for avoiding our immune system. So our immune system, they're cells that circulate in our body. We have protective barriers in our skin. Our body is meant to break down things that aren't supposed to be there, to stop bad cells, to stop viruses and bacteria, but also to stop cancer cells from happening. We actually probably do have some potential for bad cells that show up, but our body recognizes them as normal and our immune system can take care of them. Well, cancer cells find ways of avoiding that. Enabling replicative immortality. Basically, these cancers, along with something here called resisting cell death, they develop the ability to actually just keep propagating themselves, growing, dividing, and they turn off a signal that is actually supposed to be present in dividing cells, which is called programmed cell death, or apoptosis is a fancy name for it. Our cells should die when they're supposed to. When a blood cell is no longer functional and normal, it's supposed to undergo programmed cell death, but cancer cells turn that off. They no longer die when they're supposed to, so abnormal cells can stick around for longer. Tumor-promoting inflammation. So we have high inflammatory markers that can happen in cancer. We have chemicals that get set off in our body. That's why people that have cancers oftentimes will have things like high fevers, weight loss. It's like a very hypermetabolic system going on in the body when this is happening. And tumors will actually secrete these chemicals that help promote the growth in the right environment. This part right here, activating invasion and metastases and inducing angiogenesis, are two of the aspects that we've learned in kidney cancer that are extremely important for the development and growth of kidney cancers. Kidney cancers for a long time have been recognized as very bleeding tumors, bleeding very easily. And it's because of the mechanism now of how they develop. And I'm going to talk to you a little bit about that. That's that big fancy term I mentioned to you, angiogenesis. I'm going to get to that next. So this is very important in how kidney cancers develop and spread. Resisting cell death, I've mentioned. Genome instability and mutation. This is the aspect that I think makes cancer something that we probably marvel at to some extent. This is what makes it the disease it is. It's the ability of these cells to keep altering themselves. As we give treatments to people, they work for a period of time, but these cells develop ways of just spitting out the treatments we're using, blocking them, or mutating themselves so that they no longer respond, and now those cells start to grow. It's an incredibly, brilliantly smart disease that we haven't figured out yet because it's so complicated, and it's because of this ability to mutate. So all of these things, these are all things that are going on at the level of our cells, and it's all of these factors that come into play working in concert that change what should be normal growth and destruction process into the cancer process. So angiogenesis, this is this big fancy word. All angiogenesis means is making new blood vessels. So again, this is something that is important. Our body has to develop blood vessels. We need it to connect our systems. Our organs have to be connected. We have to have oxygen flowing through our body because all of our cells need this. Well, cancer, like I said, is growth. Things that are growing need nutrition, and tumors are no different. So what happens with cancers, and specifically with kidney cancer, you will start with an abnormal cell, something happens, insults will continue to happen, ultimately it will turn into a cancer because of all those factors I showed you on the other page. You'll develop a tumor that will start to grow, and the tumor really won't have much of a blood supply at first. But what happens is as it grows, it needs nutrients. It can't keep growing if it doesn't have it. So how does it get those nutrients? Well, us as the human beings, we are the food source for cancers. But in order to get to those nutrients, it needs to find a way of getting into our system. So these tumors basically develop mechanisms for creating new blood vessels. So that's what this process actually is. Tumors develop the ability to make blood vessels that attach into our existing system, and that gets them the nutrients, the oxygen, all the things that they need. And they're very good at making blood vessels, but they make very bad ones. They tend to be very leaky, not very well done. That's why tumors tend to bleed a lot, because of this process that goes on. So what's really important about this is now that we understand that this is a big part of the process of cancer in general, but also with kidney cancer, it's actually helped us understand how we can start targeting treatment. If we can cut off the blood supply, if we can cut off the food source, then we can cut off cancer growth. This, again, don't pay attention to specific names or things that are on here, but one of the things that I want to show you that has been helpful in understanding some of the genetic types of cancer and looking at actual genes. Genes they're like blueprints. They tell us, our bodies, what they're supposed to do and become, but every cell in our body carries genes. They're not the kind of genes that we pass on necessarily, but all of our cells do have genes in them that tell them what they're going to do. So if you were to picture, I've taken a picture of a cell, okay? What you're looking at right here is the brain of the cell. This is called a mitochondria, okay? It's the brain of a cell. And what happens is we will have genes that turn on these signals that I mentioned to you. This is a normal situation. When you have normally functioning genes in the cell, so specifically in kidney cancer, here's this VHL, von Hippel-Lindau protein, okay? This is really, really important in our cells because this basically controls this process of blood development. Blood cell development and blood vessel development. When things are working normally, this is going to exist in a certain level and it's going to stop blood vessel development from happening. All right? So what happens is this little thing here, consider it a tag for destruction. It'll say, we don't need this, we're tagging it, it'll be destroyed, and there will be just normal balance levels in your system. The problem is in kidney cancer specifically, all right, the gene that controls this is basically abnormal. For whatever reason, either it's genetically inherited or there's an insult that happens in the cell itself, it becomes abnormal. And what happens is there's not enough of that around to stop the process from happening. So it allows the proteins that turn on blood vessel to development to start taking over. So this is kind of the process that happens. So you start getting high levels of signals that are going to turn on blood vessel development. And cancers, and specifically kidney cancers, express high levels of these kind of chemicals that are going to signal that we need more blood vessel development. So that's basically where we've come from. So cancer it's a disease of growth. It's a disease that needs nutrients to grow, and cancer cells are very smart at figuring out mechanisms to do that. And in kidney cancer specifically, developing those blood vessels and turning those signals on is a big part of what creates this disease and continues to propagate it. Dr. Potvin already talked to you a little bit about staging of disease, so I'll keep this one short. So basically, when we look at stage or extent of disease, there are varying types of treatments we use in kidney cancer depending on where we are. When you have early stage disease, which he's mentioned, and that would be stage 1 and 2 specifically, when it's still really, really confined to the kidney, we don't use drug treatment for that, okay? That's your surgical management, is your curative intent management in that situation. Stage 3 disease is a higher risk situation, but we still, at this point in time, as a standard treatment, are not using drug therapy in this. It's when we get to stage 4, or when there is spread of cancer to other organs in the body outside. And kidney cancer, by virtue, likes to go to the lymph glands around the kidney. So you have lymph glands everywhere in your body, okay? And this is a way that cancer cells can travel as well. They can travel through your bloodstream, they can travel through local spread, and they can also travel through these lymph nodes and the network that connects them. So if it spreads into those lymph nodes, it can also spread into the bones, it can spread into the lungs, it can spread into the liver, and up here it's showing you it can also spread to the brain. So when we start talking about drug therapy in kidney cancer, really this is where this comes into play with the drug treatments. So when do we treat it? When we get to stage 4 disease. Right now there is a lot of active research going on looking at other forms of treatment for this, other stages of treatment. So in other cancers like colorectal cancer, breast cancer, several other types, we oftentimes will do what we call preoperative treatment with systemic therapies. This is to try to shrink the tumor, to make surgery easier, to try to improve cure rates, and we actually have really good research that tells us in other tumor sites it's good to do that. We're working on that in kidney cancer. We don't use it as a standard of care yet. We also use what's called postoperative or adjuvant therapy. Therapy in addition to the most important treatment, which is surgery. Again, in kidney cancer, we're doing active trials to look at this. So the reason for doing systemic therapy in this situation, you've had your kidney cancer removed, there's no evidence of cancer elsewhere in the body. The reason for doing treatment at that point is because we want to prevent the cancer from coming back. So right now in kidney cancer, we don't do that as a standard. We know it works in other disease sites. We very commonly do preventive types of treatments in other kinds of cancers, but we need the data in kidney cancer to prove that it works as well. So this is something that I think is going to become a standard in the future. But as of right now, if you've had your kidney cancer removed, unless you are on a study asking that question, we don't as a standard use these treatments yet. So where our treatment for kidney cancer with drug therapy really is confined is in the stage 4 setting, or the setting where it has shown evidence of spreading to other areas of the body. There are, and I'm going to get into this a little bit, some controversies about timing of when we should start treatment with drug therapy, because it's not always immediately. There are also sometimes some issues when patients present with disease that has spread outside the kidney, but the tumor is still in place. So these are questions that we are working on. So now at this point, I'm just going to focus, we're really looking at stage 4 kidney cancer, okay? When you come to see an oncologist, and I'm going to skip to this slide first. So when you come to see someone like me, so if you've seen Dr. Poutler, and perhaps you've been followed, you've had a kidney cancer removed, and then evidence shows that it has come back somewhere else in the body, you will get referred to somebody like myself, who is a drug doctor. When you come to see me, yeah, not in the Rob Ford sense, but he's going to be the butt of every joke. So when you come to see somebody like me, when it comes to deciding on therapy for you, there are a lot of factors that come into play. So age is always one thing, but I'm going to tell you quite honestly, age is one small piece of the puzzle. I have a 90-year-old gentleman right now that I actually have on treatment for kidney cancer with drug therapy that I'm going to tell you about, because he's an amazing 90-year-old. He's fit, he's well, he was independent until his hip was basically destroyed by tumor, but he's functional and he's great and he is tolerating his treatment well. So your age is not going to exclude you from treatment, but we do have to factor it into making decisions, because our bodies are very different at different times in our life, and as we get older, our tolerances are not as good. So we have to be careful. We want to look at your level of health and your level of function. That means how much are you up and around doing relatively normal things versus how much are you having to rest during the day? How much are you lying in bed versus sitting in a chair? This is what we call your performance status. That's a term you may hear thrown around in clinics. We look at your other medical illnesses, obviously, because that comes into play in terms of how we can use the drugs and how you may tolerate them. Burden of cancer is really important, because this actually is one of the things I look at to help me decide, do I have to treat this person right now, or can we just watch things for a while? When we have a stage 4 cancer of any kind, we're always looking at the balance of maintaining a person's quality of life while maintaining their best possible survival. And sometimes your best quality of life and survival means not doing treatment at that moment. It means watching and waiting until the time is right. And there's a bit of an art to this. There's a lot of an art to this. You have to understand the disease and how it behaves. You have to have a good relationship with your patients as well, to, so that there's trust, rapport, and arranging the follow-up. But if I have a case of a person who had a kidney cancer a few years ago. They have one small spot that showed up in their abdomen that was biopsied. Well, we took it out. There's no other disease anywhere else. Am I going to put that person through toxicities when there's nothing there to treat? Why would we do that? She feels great. They want to be traveling, do their thing. So I'm not going to start treatment right away in someone like that. Now, if I have someone who comes to see me with multiple spots in the lungs and the bones, this is someone we're going to start right away, because the burden is greater, the risk of bad things happening, symptoms dying from disease is much higher. So in terms of starting treatment, that burden of cancer is really important. We take into account if the kidney with the original tumor is still in place. This is a tricky one. Should we take it out right away? Should we start some treatment and take it out after? This is really complex. There's a lot of interest in the medical literature looking at this, because there are implications on starting and stopping the kind of drugs we use for kidney cancer, in the sense that sometimes they will respond. If we stop therapy to go to surgery, there can be regrowth of the tumor. So it's a tough call, but there's also data that suggests if we take kidneys and with the cancer out, even in people with metastatic disease in the old literature, there was actually a survival advantage to that. So these are questions we're still answering and are interested in. Type of kidney cancer is important. Most of them are of the clear cell type, but there are other types. We don't know as well how to treat the other ones. We use sometimes the same treatments. We're doing studies on that because we don't really know. But most of the data that's published is based on clear cell cancer. So sometimes the type of kidney cancer will impact the type of treatment we're going to use for you. The prognostic group is what I showed you here. This is something that is really important to us as treating physicians to help give you information about how you may do, and it helps guide sometimes our treatment choices. What I'm showing you up here, this is data that has been studied looking at patients who have received treatment for kidney cancer with our modern drugs. And they looked at all these patients and their outcomes, and they analyzed all of these patients to see if there were things about the patients or their disease that would predict how they would do. And based on all that data, it was large, there were thousands of patients in this, they were able to break patients into what we call a prognostic group, and good, intermediate, or poor. What that means is depending on what factors you have and how you fall into this group, it's going to tell us something about what your odds are for survival. It's also going to tell us something about how we should treat you and when. So when I see you as an oncologist, even though you don't know this, when I'm doing your blood work and when I'm looking at everything, I'm also putting you into one of these groups to help make that decision. That's also going to help me talk to you. If you're somebody that wants to hear numbers, I can give you numbers based on this. But the truth is, they're just numbers, right? Because there are people that may fall into any one of those groups and actually make a lie out of all of those statistics. So it's a guide for us. But this is something that you may hear about, these prognostic classifications. This is where it comes from. So when it comes to treating, you come to see me, we decide you're someone that we want to do treatment in. The first thing to tell you is chemotherapy doesn't work in kidney cancer. It's an interesting disease. There's a lot of interest in how the immune system plays into this, along with the vascular or the blood vessel side of things. And one of the reasons that kidney cancer has been so challenging in the past was because chemo doesn't work in terms of the traditional cytotoxics that we use. We used to use a lot of immune-based therapy, drugs called interferon, another one called interleukin. This was based on knowing that in the past there are reports in the literature that people have had complete what we call spontaneous regression. Tumor that was there, that was kidney cancer, that just went away completely by itself. And the theory behind that was that somehow the person's immune system had taken care of the tumor. So it's been a very different cancer. That and melanoma have been entirely different in how they've behaved and not behaved according to how we've treated in the past. So these therapies, for the most part, are no longer used. Some places in the United States will still use what is called the interleukin therapy. It's very, very specialized. It is very, very toxic. It has to be given in very specific centers with intensive care units because of the toxicity of the treatment. It is associated with sometimes what we call very durable responses, basically cure, even in patients with metastatic disease. But it's very hard to identify who that patient is that's going to respond to it. So, how do the drugs work? Again, this is a big fancy diagram, but essentially I'm going to talk to you very briefly about the drugs. This is a cancer cell. This is all that machinery. This is a simplified version of how complex cancer is, and this is why we don't have a cure yet, because it's so complex. But I'm going to talk to you, the treatments I'm going to talk to you affect this part. So if this is the cell, this is the outside of the cell, signals being sent in, turning on this machinery that's driving the cell, making it grow, divide, and spread. So some of the drugs I'm going to talk to you about work up here at this level, and another one of the drugs I'm going to talk to you works further down here in the path. Okay? So when I say first-line treatment, what this means is you've not received any systemic therapy for your kidney cancer. You're coming to see me, and we know you have disease that has spread. We want to treat you with something. What do we use? So we use drugs that are used to inhibit that blood vessel formation and inhibit the factors that lead to this activity in the cancer. By inhibiting that, we can inhibit the growth spread of this cancer and cause shrinkage and response. These are the two drugs right now that are currently approved and now funded for kidney cancer in the first-line setting. So these are the things that you will most likely hear about from your treating doctor if you're going to undergo therapy. One is called Sutent or sunitinib. One is called Votrient or pazopanib is the other name. They're extremely similar drugs. They both work by very similar mechanisms of action, which is on that surface of the cell. They block a signal from being sent further down the path. So they turn off, they take away the signals to turn on that machinery to make the vasculature. Okay? Sutent is given once a day. We play with the schedule, and this is thanks to some data from Dr. Bjarnason, who's a fantastic Canadian researcher and oncologist. So if you are put onto Sutent, there may be some discussion and there may be some changes in how the drug is given to you. It may be started daily, given to you for a few weeks with a break for a couple of weeks. in what we call a 6-week cycle, or it may be given to you slightly differently. That's going to be based on you, your overall function, and like I said, your performance status, and the discussion with the oncologist. So there can be some variability. For example, my 90-year-old gentleman, I'd never give him the starting standard dose they use in studies because I'd probably kill the poor man. So I've started him on a much, much lower and continuous dose, which he's tolerating very, very well. And then we can escalate if he's tolerating it. The other drug, pazopanib, is given twice a day. It works very similarly to the Sutent. They're very, very close, and they've in fact been compared to each other in studies. They both seem to work equally well. It is also, this one is taken continuously, and we don't stop it unless there are actual side effects or evidence of disease growth. Both drugs have improved survival in kidney cancer. It is absolutely fantastic where we have come with treatment of it. They definitely both do. They both shrink tumors. We give both cancers until we have evidence of disease growth and progression, and that is somewhat based on the gestalt and the impression of an oncologist as well, because you can sometimes see a CAT scan. Say you have a CAT scan done and it says there is 1.2 centimeters to 1.4 centimeters. Well, for me, if that's all there is, there's no new spots, someone's feeling well on treatment, I'm not going to stop treating because of that. That's not a clinically significant change to that person. So there is, again, an art to deciding what truly represents growth or progression of disease, but we give these drugs until that time. We will sometimes use breaks in treatment for side effects for patients, but we're very careful about it. I'm very careful about it because one of the things that we know is when we stop these drugs, and this is data again from Dr. Bjarnason and others, when we stop these drugs for extended periods of time, we can see regrowth of the tumor. So we're very careful about how long we keep people off if it's not for evidence of disease progression. Once the symptoms are better, we tend to go back. So we want to minimize those breaks. On average, when you look at the studies, people stay on these treatments for about 8 months. But again, I've said people can make liars of the statistics. Those are based on papers. I can tell you stories, not necessarily of my own yet, but of people who've been on these therapies upwards of years because they've responded and tolerated it so well. So there can be very prolonged responses with them. There's going to be more specific discussion, but the things that you need to know, even though this is a pill and it's not chemotherapy, this is not just a baby aspirin. These drugs can be associated with major side effects. They can make you very tired. They can really screw up your bowels. They can give you quite significant high blood pressure. So if you have high blood pressure at baseline, that has to be watched very carefully. You can get a sore mouth, sore hands, sore feet with them. You can get sores in the mouth. You can have rashes with them. You can have problems with your thyroid and your liver function. These are all common things that we need to watch for and manage with you. There can also be very serious complications like holes in the bowel wall or serious things like blood clots. So they're not benign treatments to be taken lightly. They need to be managed by people that know what they're doing with the drugs. That's really, really important. When you have had treatment in the first line, the reality is when we've got stage 4 disease, it is incurable disease. Our goals are to keep you living as long as we can, feeling as well as we possibly can. But the good thing is, if you have that first line treatment and things start to grow, we actually do have other therapies that we can give you in the second line that also have been shown to improve responses and outcomes in patients. So the current one that we have available is a drug called everolimus, or Afinitor is the other name for it. This is the one that works further down in that pathway that I showed you. So it's a different mechanism of action, but still functioning within that same blood vessel, blood growth stimulation and proliferation pathway. Again, it's daily dosing, and when we use this drug with you, we give it to you until we have signs of cancer growth or until you're experiencing side effects that might be intolerable for you. I'm going to skip that because it's the same thing. The side effects from this one, again, even though it's a pill, they have some similarities because, again, they're functioning within the same class. But the problem is there are some different ones. A specific one to this that we have to watch for is inflammation of the lungs. That can be serious. But similar things like high blood pressure, mouth sores, rash, other ones are very common. So again, they may sound like fairly benign symptoms, but again, they're not. And we have to dose and watch things very carefully. There are other drugs that have been used and are available, and it depends on some funding issues. There's a drug called sorafenib and other temsirolimus that are out there that you may read about. They're not used nearly as commonly anymore because we have found these are the other ones that are the most effective. up-and-coming treatments that we're going to probably end up using in kidney cancer. There's a lot of interest, as I've mentioned to you, in immune-based treatments. So there's a lot of work being done in vaccine-based therapies. And a very exciting one that we're looking at is a drug called nivolumab that is being tested. And then again, that is working more on the immune side. It's working on certain particular white blood cells called your T cells. So these are therapies that we're going to be hearing much more about. We're doing studies with them. Again, they've been associated with excellent and very long responses in patients. Lots of research going on new targeted therapies in this situation. We also sometimes use radiation. We also sometimes use surgical removal of metastatic sites if they're isolated. So there are a lot of things that we do to manage kidney cancer that aren't always necessarily about the drugs. Two drugs to mention to you. Kidney cancer goes to the bone very, very commonly. And when it does, it can do really bad things. You can have breaks in the bone, fractures. You can have pressure put on the spinal cord because of tumor growth in the bones near the spine. These are really serious, and they can obviously cause major, major impacts and problems for patients. There are medications that we use specific to help the bone. There's an intravenous one called Zometa that we use on a monthly basis. There's an injected one that goes under your skin, kind of like an insulin needle that we use monthly as well. And both of these drugs have helped prevent or delay sometimes these events from happening. So when we can and when appropriate, we do offer these to patients who have kidney cancer that has spread to the bones to help prevent some of those complications from happening. There are some differences in the two drugs. For the sake of time, I won't sort of get into much detail about them, but they are things that may be discussed with you or your family members if they're seeing an oncologist because of disease that has spread elsewhere. Brief thing to say about clinical trials. Basically what these are, they're studies. We do them to test out therapies and treatments to see if they work. We compare them to standards, or we compare them sometimes to what we call a placebo or a fake, if there isn't something that's a specifically accepted standard in that situation. At this time, like I said, we're testing before surgeries, we're testing after surgery, we're also testing other therapies in different lines in the stage 4 setting as well. We do participate actively in clinical trials here in London, and we do have several going on. We are associated with multiple international organizations as well as the Kidney Cancer Network and NCIC in Canada. So there is always something going on. We are always trying very hard to make sure that we have therapies for each line of treatment so that if you're coming in and you're a fit person and are interested, we can offer the opportunity. They require more frequent visits, they require a lot more imaging, and some people find that a benefit. Some people find it very difficult if they have to come from further away. But one of the things it does do is, it is how we figure out how new treatments work. It's why we have what we do in kidney cancer now because of the studies that have been done. But also if you participate on it, it gives you a shot at having a treatment that may become one of the new standards down the road before there's access to it. So it's really, really important that we keep our trials going. It's really important that you as patients and family members come and participate in them if they're possible. So basically, our survival is much better than it's ever been. It measures on average in years now for people who have stage 4 kidney cancer, and it's because we are catching it sooner and we're actually curing more of them with the surgery or even just watching some of them. But really, our drug treatments have significantly improved in the metastatic setting because we understand much more about the process of why cancer grows, and specifically in kidney cancer, why it grows. We're also much more careful about how we manage this. We're very careful about how we manage the side effects, so we're not killing people with the treatments that we're using. There still are a lot of unanswered questions. A lot of exciting therapies coming down the pipeline. So this is a disease that's really growing and exciting. And, you know, it's one of those situations where I'm pleased to say it's a chronic illness now. It's not a death sentence for people because of, you know, the treatments that we have and that are ongoing. So please, if you have the opportunity, I would encourage you to participate in the trials whenever you can, because you'll help us really push things further along much more quickly. So I'll leave it at that. And I think Lori and Brian are going to come and talk about toxicity management.